Hello, this is Bob Philpot. I'm the program director at Mississippi College Physician Assistant Program, and I'm here to provide an overview of the topic, providing new methods of care, and I'm going to briefly summarize some of the scholar projects. First, I'll give you a little bit of the overview of the topic, and then we'll talk about a synthesis of the scholars' slides. Providing new methods of care uh, is an area where the students and then scholars explored new things that are being done to improve the efficiency of care or the access to care at their sites. In the synthesis of the care, I found that the presentations fell into three broad categories within this theme of new methods providing care. First was improving efficiency and maximizing resources. There were about 4 of the projects that fell into this category. 5 of the projects fell into the category of improving access and participation. And then there was one that focused on assessing the knowledge of the subjects. And I'll go through each of those very briefly. The first was done by Tiffany Kovas, and please excuse me if I mispronounce some of these names. Tiffany looked at methods for provider panel size and which one would be best for improving outcomes and quality of care at her site. Casillas Guy looked at collaboration of Adelante with other local nonprofit organizations, ultimately to apply for a grant in order to meet community health needs of 2 of the hospitals. Bianca Mondesir looked at a UCLA domestic violence intervention screening video and the feasibility of providing that video to patients as they waited, looked at the average waiting time for patients and wanted to know if that would affect the patient flow adversely. Melissa Brito was investigating the area of medical nutrition therapy and billing for such services. She wanted to know if the specifications for billing requirements differed among the health insurances. She specifically compared Medicaid and Medicare, and she made some very good recommendations that I'm sure she'll share with you. Carla Ruiz, in the area of improving access and participation, Carla looked at the HOPE team and how they utilize their resources. She had some good recommendations to include increasing laptop turnaround, installing lock boxes, doing some other things like that. I think it was some of the recommendations were very clever, and I'm sure she's willing to share those with us as well. Kathleen Heinzelman looked at the clients who utilize the Matthew Walker Comprehensive Health Center and their healthcare needs, and looked at ways to improve access and foster health promotion. And the title was the Back to School Bash, where over 200 people attended this bash and increased participation from the previous year. Nancy Chang investigated various models for patient care medical homes, looked at a really wide variety of strategies that people are using to achieve these patient-centered medical home goals. Rebecca Cedillo looked at some of the forms, the information and intake forms that were being used at her site, had those translated to Spanish in order to support the implementation of this comprehensive healthcare for the community program, with an emphasis on enrolling or increasing the enrollment of patients into the program. Lauren Yu looked at reducing ER visits through telephonic information by providing information to frequent utilizers of the emergency department. And finally, Joseph Nelson, he set about to assess the knowledge of healthcare providers about patient-centered medical homes at Jackson-Hines, which is currently transitioning to the PCMH model. His was a cross-section study looking at the knowledge of 62 providers, and he came up with some very interesting results there and looked at exactly what they do and don't know about the PCMH.
Now we'll hear from our PCLP scholars who will each discuss their projects.
Hi, my name is Tiffany Kovis. I'm a fourth-year medical student at Wake Forest. I was placed at Ultimed in Los Angeles, and my assignment for the PCLP program was to work on helping develop appropriate sized provider panels for Ultimed. So first of all, I didn't know what a provider panel was, which is the number of patients that one provider sees in a year. So I conducted a literature search to determine, how should Ultimed use its resources and time, and what system should it use to design the best provider panels. My literature review included searching for adjusted case mix and provider panel size adjustment, and I also looked at the Institute for Healthcare Improvement and had a conference call with them, and some other online sources and other sources that were recommended to me through faculty. So the key findings, what I found was that the average panel size tends to be about 2,300, which is way more than any primary care provider can handle, and physician burnout is high. So there was a group health study that showed that if you bring the provider panel size down to 1,800 and increase visits from 20 to 30 minutes, the outcomes were better for patients and there was less physician burnout. Each physician had fewer daily appointments, only 7 for a half day, and the cost was equivalent with improved outcomes, so that was important. I learned a lot about mid-levels and the best way to use them effectively. So PAs and nurse practitioners, the most effective use tends to be for health maintenance and for common problems. So possibly supporting the provider, the physician provider, or having a panel that is a healthier panel can be a good way to utilize mid-level practitioners, or having them work on a lot of health maintenance related topics like pap smears and different things like that. And also innovative paradigms such as group visits can have a lot of promise for expanding provider capacity, and these could be run by physicians and or mid-levels as well. There's a great model in OD with centering where they use a group model that's had very good outcomes. So my recommendation for Ultimed was to have smaller panels with longer appointment times, and work on developing innovative paradigms to increase capacity instead of having an overly large panel and compromising quality. And since Ultimed is moving towards more quality over quantity with the new Affordable Care Act, this is a timely time for this research as they're trying to move more towards outcomes-based models over fee-for-service models. I really enjoyed looking into this. I found it very interesting. I thought it was great to look at the literature and see what is intuitively true is also true from the literature. I think it makes sense that if you spend more time with a patient, you'll be able to figure out what's wrong with them in one visit maybe instead of several visits, which gets to be quite expensive. Um, so thanks so much for your time, and
Hello, my name is Casilius Guy. I attend Morehouse School of Medicine located in Atlanta, Georgia. I am currently in my second year of their medical degree program. For the NML PCLP Scholarship Summer Program, I was placed in Phoenix, Arizona. The site I was assigned to was Adelante Healthcare. It was here that I was able to assist in a truly unique project entitled The Health Continuum. The objective of this project was to assist in the collaboration of Adelante Healthcare with other local nonprofit organizations, ultimately to apply for a grant offered by Dignity Health in the hopes of meeting the community health needs of two of its hospitals. To apply for the grant, three nonprofit organizations had to partner together. The following community partners were chosen because they had similar missions and were willing to cooperate with one another. In order to plan for and work out logistics to meet the needs of the selected community identified by Dignity Health's associated hospitals, several meetings were conducted among Adelante Healthcare, the Harp Foundation, and Matthews Crossing Food Bank. Within the meetings, the following themes were discussed: location and target population, mission and goals of the collaborative efforts, letter of intent, budget for the project, and collection and evaluation of data. From these meetings, some key decisions were made. We chose to center the project around Dignity Health's East Valley community, serviced by Mercy Gilbert and Chandler Regional Medical Center. One of the main goals of the health continuum is to reduce the 911 calls and emergency department visits as first response to primary health care. After assessing the cost of each organization involved, we came up with a collective budget of $96,804. This is very good considering the grant is willing to pay a maximum of $100,000. The data will be evaluated and analyzed using pre- and post-test qualitative surveys, percent decrease of the emergency department visits, and percent volume increase of the health center. My recommendations for the project: the Health Continuum project will be very beneficial to Arizona. Therefore, it should not be wholly dependent on grant money from Dignity Health, which may or may not get approved. The letters the leaders of these nonprofit organizations need to apply for other grants as well to help fund the program. Other nonprofit and even for-profit organizations will need to be incorporated to help lower the costs and to make it sustainable. In terms of data collection and analysis, someone should be put in charge of closely communicating with the hospital's emergency departments. Their contact information will be made available to the emergency department so it can be given to patients who come to the ED for health problems that are not necessarily emergencies. The contact person will be in charge of making sure that the patient was assisted through the health continuum. This then provides a more accurate way of determining how many people were deferred from the emergency department through the program, and collecting more accurate data has a greater chance of getting funded. Finally, I would just like to say that as a recipient of the NML PCLP scholarship, I want to say that what a great experience I have had. This experience has allowed me to gain experience in grant writing and also allowed me to work alongside other members of the community. The leadership, clinical, and business skills I have learned here will certainly benefit me in my future endeavors.
Hello, my name is Melissa Brito, and I'm a recent graduate of the Philpot Israel School of Nursing in New York City. This summer, I was placed at Adelante Healthcare in Phoenix, Arizona. My project involved investigating whether medical nutrition therapy is a billable encounter by a registered dietitian and to obtain the specifications for billing requirements among the different types of health insurance used at Adelante Healthcare, such as Medicaid, Medicare, and private health insurance. In medical nutrition therapy, registered dietitians provide a full nutritional assessment, interventions, and monitoring of disease process, such as diabetes, renal disease, weight management, allergies, and eating disorders, ultimately helping the patient in overall prevention of further complications. As a community health center, Adelante does have a demand for a registered dietitian on staff. Medical nutrition therapy services could be billed by a registered dietitian. Adelante would be hiring one to provide these services. To gather the information regarding medical nutrition therapy, I used various sources. I contacted area registered dietitians, which I had found through online medical plan information, through different contacts I had already made. Some were very difficult to reach or engage in my project, and many of them had limited information due to lack of experience with direct billing and the resources available out there for them. And many did work in private settings and in hospitals where they were not required to know much about billing. I also contacted medical insurance companies directly, which I found only disclose information when provided with direct client specific policies. And this led to very specific data, and this type of information didn't really apply to a lot of patients of Adelante, for example. It was very direct information and very specific. The information provided from medical insurance companies are also given verbally mostly, which is very limited and general. Again, I also searched federal websites and the Academy of Nutrition and Dietetics, which did generate more information about Medicare coverage than any other type of medical health plan. I found medical nutrition therapy services is a billable encounter by a registered dietitian. While the billing guidelines are not concrete for Medicaid, and the information varies very much for private health insurance policies, Medicare does have very specific guidelines and abundant resources available for guidance and billing. Medical nutrition therapy can significantly provide a better quality of life as patients learn the information and tools they need to manage their disease. An RD should be hired by Adelante Healthcare to provide these services because through collaboration with the patient's providers, RDs help in supporting the treatment plan for those patients in need. Thank you very much for listening.
Hello everyone, my name is Carly Reese. I am a student at William Carey University, College of Osteopathic Medicine in Hattiesburg, Mississippi. And my study placement was the Healthcare Center for the Homeless in Orlando, Florida. My main project was to evaluate the HOPE team, and I wanted to determine if they are efficient in their use of resources. So the definition that I used was from the Institute of Medicine, and it defined efficiency as avoiding waste, including waste of equipment, supplies, ideas, and energy. And that really helped me come up with the project. So I ended up collecting data from June 3rd to July 10th, And the way I ended up doing this was looking at the HMIS intake forms, comparing that to the clinical electronic database, and seeing if these patients continued on, if they actually met with people they referred to. And then the HMIS forms were the bulk of the data, because that told me in their initial contact, did they recommend, whether it's for ID or health service or housing. The main thing that they have on their CQI and how they determine whether or not they're completing their objective is to connect chronically homeless with referral services. So overall they did. They actually connected chronically homeless with services just by referral. So the actual objective was not about whether they followed through. That was just a separate part of the data that I looked at, but whether or not they referred. And overall, they did. There are three main areas that I saw that there weren't a lot of things happening, and these areas actually blocked care and also could hinder trust in the relationship with both the clinic, the HOPE team, and the patient. So those three areas were technology, transportation, and the providers themselves. Technology, it could be anything from not having a laptop. One outreach specialist had a laptop, it broke down, and it was 2 months since she last saw her laptop. So she didn't have one, and that's actually the nurse case manager that they hired. And another outreach specialist was even afraid to bring out her laptop because she was afraid that it would be stolen when it was in the car. And so there are little things that we recommended based on the things that I saw. So another area was transportation, and that has to do more with attitude, beliefs, and how the HOPE team actually uses their time. So the HOPE team, although they're supposed to be going out and finding new patients and going out into the campsites, they actually spend a majority of their time transporting people back and forth. And then another area of that was attitude and belief for the clinic. So a lot of people in the clinic saw the HOPE team as just this taxi that cared. They were always there. Their provider that said, hey, if you need a ride, just call them. And that's great because everyone at clinic wants these patients to get the best quality of care. Unfortunately, you're recommending someone who doesn't have the time. The third area would be the providers themselves. There's one HOPE team provider, besides the nurse case manager that goes out with the team. And the main provider will go out one to two times a month and actually go out into the wards and see patients that the nurse case manager and other specialists say are priority. Otherwise, these patients come to the clinic, have HOPE team patient spots with this provider, and will get care there. Unfortunately, we saw a lot of those appointment spots being filled up. And then we also saw a lot of just walk-ins that were no-shows. And so this basically told me that they came, they showed up, they waited for a couple hours, and they weren't seen. They left of their own accord. But still, you have someone who lives in the woods for 15, 20 years coming into a clinic, not being seen for 3 hours, and then they leave. So for different reasons, they can't stay. So that was my overall project, and the recommendations were made. Some of them are listed on the slide. But I hope that I was able to express what I did. It was such an awesome, an amazing opportunity to work with some people, to network, just to actually get to know the patients and know more about the subculture of homelessness. So thank you, and have a great one. God bless.
Good afternoon. This is Kathleen Heinzelman. I'm a student nurse midwife at Frontier Nursing University based out of Hyden, Kentucky. I am a senior and should finish the midwifery program by the end of this year, where I will also be a women's health nurse practitioner. For the GE Summer program, I was in Nashville, Tennessee at the Matthew Walker Comprehensive Health Center. And as you can see from my executive slide, my service learning project was to participate on the planning committee of the Back to School Bash, an example of health promotion and community investment. Our objective for this event was to provide clients who utilize the Matthew Walker Comprehensive Health Center for their healthcare needs an opportunity to participate in health promotion classes, children's activities, and to garner school supplies at a family event involving community partners. And some of those community partners included Delta Dental, the Meharry Medical College, Matthew Walker, Vanderbilt Sickle Cell Clinic, and many others. Our methods were based on the health promotion model by Nola Pender, PhD, RN, who is also a member of the Fellowship of the American Academy of Nurses. And this, as I said before, was my GE Primary Care Leadership Program Service Learning Project. And the key findings that we found from this event were that over 200 people attended the Back to School Bash. This was an increase of over 50% from the previous year. Over 200 backpacks were given to families who needed supplies for their children to begin the new school year, and this was also a 50% increase from the previous year. The recommendations that I had were to continue the Back to School Bash annually for the clients of the Healthcare Center. This can be an annual fun family event. The data collection methods that we utilize, I think, need to be looked at, revamped, and a clear method of how to give them out and collect the data. I think that's important. We tried to collect some data this year but had some problems with knowing who should get which survey tool and those kinds of things. I do think that the planning should start much earlier, and I think that there should be an increase in advertising, especially there at the center. There should be signs hung up and banners and things for a couple of weeks before the event to remind the clients who are coming in of what's going on. And I think this will increase the community involvement because it will be well known in the community that this is going to occur every week. Now for a reflection, I really believe that this is a good method to get families into the healthcare center and to see it as an integral part of their lives. They don't have to wait and just come in when they're sick, so that the people there who work there and the providers will have more of an influence on them to help them do positive change in their life about their healthcare needs, and they can become proactive in what they do. I also just had a really fun time with it. It was great to see the children there having a good time. It turned out really well. The weather was good. The food was good. It was just a great, great event. And I think it will be remembered by many of the clients there. So I just really enjoyed being a part of the program and a part of the Back to School Bash. Thank you very much. Good night.
Hello, my name is Nancy Chang. I am a family nurse practitioner student at the University of California, San Francisco. I am entering my second and final year of my program. I was placed in Phoenix, Arizona at Adelante Healthcare. My project was to research various models of the patient-centered medical home to gain knowledge for implementing a PCMH at an Adelante clinic. Basically, the key findings are that long-term data is insufficient to determine any financial savings or clinical improvement. Improvement in preventative services and patient satisfaction were seen, and a wide variety of strategies were used in implementation. No tried and true method exists. Impact on health outcomes or healthcare cost remains to be seen. Will the PCMH improve the way care is done now? We don't know, but I am staying positive. The best strategy to implement a PCMH may be to design it specifically to the needs of a target community. The tricky part is to also design a strategy to effectively measure outcomes, such as cost savings and clinical improvement. I went into this project thinking that there would be a lot of really great research because I've heard so many people talk about the patient-centered medical home as the solution to our healthcare problems. What I found were many opinion pieces and case studies, I managed to find a systematic review that had found over 5,000 related articles, but only 31 were peer-reviewed studies that were rated as good or fair. I was very surprised by how little quality research existed on the topic given the expectations for the patient-centered medical home. Another point was brought to my attention while doing this research, and that is personal choice. What if patients don't want to keep their appointments or use the resources available? What if they want to bounce from one medical home to another? That is their right. But that does not decrease our financial burden. In fact, these patients are the ones that are likely to fall into the cracks and be readmitted to the ER and hospital. What can we do about these types of patients? And these questions about personal choice? What I learned is that evidence-based practice is very important. Highly anticipated innovations will come along. Popular ideas will circulate, but that does not mean that the evidence is there to support these new ideas. As responsible practitioners, we need to always review the research for ourselves in order to help our patients make good decisions. Thanks for listening.
Hi, my name is Rebecca Cedillo, and I am a second-year family nurse practitioner student doing my Master's of Science in Nursing at UCSF in San Francisco, University of California, San Francisco. And I was placed this summer at Wesley Health Center in Phoenix, Arizona through the Primary Care Leadership Program. It was really a privilege to be a part of PCLP this summer. And my project was to implement a program called the Comprehensive Healthcare for the Community program. When I came to Wesley, they already had received a Dignity Health grant from the Dignity Health Foundation to develop a program that would help capture some of the uninsured and underinsured patients who are overutilizing the emergency room at St. Joseph's Hospital for services that could be better given to patients in a primary care setting. So they had received the money from the grant and had a team, but hadn't enrolled any patients yet due to some paperwork that was still coming through from the hospital's side of things. So what we decided to do is to develop and pilot some of the patient information and intake forms to be able to have some infrastructure in place when patients began or when patients were ready to be enrolled once the paperwork came through. So I worked with the care coordinator who was already working on this grant to adapt some care management forms from UCSF, their Department of General and Internal Medicine, and from some other resources, and we translated the forms from English into Spanish as well. We put together a patient needs assessment, an individualized action plan, some questionnaires about recent ER use and hospitalizations, and then some patient information forms as well that they would receive in the hospital in order to get connected to the services in this program. And then we piloted the forms with patients who qualified for the program. I forgot to mention patients with diabetes, hypertension, asthma, or obesity would qualify for the program based on their lab work. So we were kind of trying to capture patients with uncontrolled diabetes, hypertension, etc., high BMI, frequent asthma inhaler use. Key findings is a bit of a misnomer for this project since we didn't actually do any research, but we did complete the forms, translate them into Spanish, approve them, and pilot them at Wesley, demonstrating the feasibility of the system for enrolling patients into the program. And some recommendations that I left Wesley with through conversations with the care coordinator were to make sure to include ample time for patients to get a comprehensive needs assessment during their first intake, so half an hour with the care coordinator to really be able to assess, where patients falling through the cracks. Is it that they can't control or manage their medications very well on their own, that they need assistive devices at home, they don't have adequate transportation, finances, etc. Also recommended to do some monitoring and evaluation to be able to collect data and monitor whether or not this program is successful, possibly for publication. Since care management is an emerging field, there's a lot of momentum behind it in healthcare right now. And to also establish a really good working relationship with St. Joseph's Hospital to ensure sustainability of the program. That just means meeting with discharge planners and really getting buy-in from the staff about what we would be giving patients access to through this program. Some reflections on my summer, besides that I'm just really grateful to have had the chance to learn from the incredible patients and staff at Wesley. I'm really hopeful that this program will be able to serve some of our most vulnerable high-risk patients who really aren't being served very well by the current healthcare system. So I'm looking forward to seeing how well this program goes. Thank you so much, and take care, everybody.
Hello, my name is Lauren Yu, and I'm a third-year medical student at Morehouse School of Medicine. My site placement was with Ultimed Group in Los Angeles, California. This is my second year participating in the PCLP program. I decided to focus on the same topic from my first year using a different approach to hopefully yield stronger results. The telephonic approach is supported through various research studies. In a study conducted by Constantino et al., it was shown that Medicare patients contacted via phone by qualified associates near their discharge date had a decreased 30-day readmission rate. A patient-centered pharmacy program intervention conducted by Moore et al. Focused on a select group of high-risk patients who agreed to participate in a medication therapy management program in which 3 consultations were conducted. The results showed that members of this group had decreased inpatient readmissions, emergency department visits, and healthcare plan-related costs. Currently, $38 billion goes towards non-urgent care each year, more than half of which is avoidable. The purpose of my intervention is to decrease this utilization and to reach over 300 identified frequent utilizers. Myself and the health promoters through the Health Education Department at Ultimed aim to provide education that was engaging and understandable through a developed script. The script was made by referencing the book, What to Do When Your Child Gets Sick. Topics that were covered include vomiting, diarrhea, constipation, earache, and fever. Information about the nurse advice line and after-hours care was included because in recent years, Ultimed began providing extended hours at selected sites. Some clinics are now open until as late as 10 p.m. This helps to provide access to individuals who can't make appointments during regular business hours. The utilizers who were targeted in the study were identified using an automated list that is generated weekly. A pediatric group was focused on to narrow the parameters of the intervention, so those who are 17 and younger were reached. This group was also chosen because this population usually has less underlying medical conditions which could be difficult to address over the phone. Surveys will be administered to the parents of patients who are 17 years and younger, as well as the script. A 6-month follow-up will be conducted to determine the influence of the intervention. Some results have actually been reported. Out of 165 patients who were called, 59 of these patients were reached. Phone conversations lasted between 3 and 22 minutes, with an average of about 12 minutes. My hopeful end result goal is to not only reduce emergency room visits, but to divert non-urgent care to urgent care. This would allow for a better use of funds and would provide urgent care centers with more reimbursement. Our participation in the Primary Care Leadership Program has been extremely rewarding. I was introduced to mentors with a wealth of experience working with underserved populations and providing health education. I was challenged to address community needs in a creative way when conventional methods did not yield promising results. The skills gained during my time at the program will help me to appreciate patients' backgrounds and social determinants while treating illness. Since I plan to work with underserved populations in the future, this experience helped provide insight into barriers that patients face while seeking treatment. Thank you.
Hello, everyone. My name is Joseph Nelson. I am a GE NMF PCLP Scholar of 2013. I am a second year medical student coming from the Sophie Davis School of Biomedical Education, and I'm currently at the NYU School of Medicine. My GE NMF PCLP scholarship was done in Jackson, Mississippi at Jackson Hines Comprehensive Health Center under the direction of Dr. Jasmine Chapman, and I focused on assessing the knowledge of providers about patient-centered medical homes. In doing this research, I conducted a cross-section study that surveyed providers. Are a total of 62 providers working at Jackson Hines clinics, and it was a 10-question survey that was disseminated to 50 of the providers. Some of them were actually on vacation since it was the summertime. The providers included MDs, DDSs, and nurse practitioners. Out of the 50, 19 providers participated for a response rate of 32%. My goal was to assess the knowledge that they had in regards to transitioning into a patient-centered medical home, what it means to them, and the practical implications behind it. The survey itself had questions that asked, what is a patient-centered medical home? It asked them to address the 6 must-pass elements of a patient-centered medical home. How comfortable were they with the principles of patient-centered medical homes, such as person-oriented care, the safety measures, the use of electronic health records, things like that. And it also asked for them to list the strengths and weaknesses of Jackson Hines in regards to its transition to becoming a patient-centered medical home. Based on the results that I attained from the provider survey, Jackson Hines providers have an overall understanding of what a patient-centered medical home is. However, they are not familiar with the standards necessary to achieve the status set forth by the National Committee of Quality Assurance, such as many of them were not familiar with all 6 must-pass elements. They were not familiar with, or they said that they were somewhat familiar with the principles that guide the coordinated care by patient-centered medical homes. And some of them actually, rather most of them, thought that the goal of primary care was to have the primary care physician act as gatekeepers of medicine, which we found to be inaccurate because we don't want to stop individuals from facilitating care when it is needed, but we would rather make sure that patients are guided to the correct tertiary care specialists when they need the help. In regards to that question specifically, 57% of the providers incorrectly listed primary care providers as gatekeepers of healthcare. As a recommendation, a presentation on patient-centered medical homes should be given to providers who are currently working at Jackson Hines. The presentation should provide information on the history, the principles, and the must-pass elements of patient-centered medical homes. The presentation should also refer to the requirements to satisfy CMS meaningful use, which is used to pay the physicians when we're making sure that they're actually following the guidelines and standards of becoming a patient-centered medical home. So we want to make sure that the physicians themselves are familiar with how they are being paid. And the presentation can be provided in a paper format to new providers as a standard procedure, and it can also be available to all staff members as a template on eClinicalWorks, since we want to make sure that individuals are becoming more and more comfortable with eClinicalWorks as the method of communicating, addressing patient needs, and whether it be it not for the purposes of becoming a patient-centered medical home. Currently, Jackson Hines is applying to become a stage 2 patient-centered medical home, and the goal of this presentation is to ensure that the physicians, once they start getting into the process of informing them, are very well aware of the practices necessary to maintain their medical home status, so that it's not so much of a, if you want to say, a harsh look when they actually are hit with the fact that, yes, we are a patient-centered medical home. So this was my research project. Thank you.
So here's some discussion questions. What recommendations do you have for someone who would like to continue the project that you started? What do you feel are the most significant barriers to healthcare access in the U.S.? And what do you feel is the one most important outcome to monitor when assessing the health of Americans? It's been a pleasure to participate in the PCLP program, and I wish you all the best of luck in the future.